Good evening, everybody. My name's Matthew Kerr. I work as a consultant to the supplier ReaCare, who are those that are hosting and bringing this webinar to you tonight. But most important is our guest speaker who will be joining us a bit later, Alison. For those of you that don't know, Alison is a wound specialist on the Sunshine Coast. One of the earlier users of blue light therapy for treating wounds, and as such is somewhat of a super user, I think we would describe her as. And she has some pretty remarkable cases to share with you across a broad range of etiologies. I think the term transforming chronic wound outcomes is probably quite fitting of what we're going to be looking at tonight. So we're looking forward to Alison joining us very shortly. Before we start, I'd just like to make an acknowledgement of the traditional custodians of the land in which we gather today, whether that be virtually or physically, and pay our respects to their elders past, present and emerging. We extend that respect to Aboriginal and Torres Strait Islanders people. We acknowledge the traditional owners of the lands in which we are on today. Throughout the session, if you have any questions, please use the Q&A box down the bottom. We'll collect all of the questions you have together for the end for Alison, for myself, or possibly for the both of us. We'll do our best at the end to get through as many questions as you can pose for us. In the event that we miss any out, we'll obviously collect these up and email them out to you, but rather than trying to dive in, if you can just use the Q&A box, it's a lot easier. Obviously, sometimes there's the same question popped up, so we'd like to just answer it once for everybody. So without further ado, I would like to kick off this webinar tonight with a very light brush of photobiomodulation and what blue light therapy is for wound care. I appreciate many people on the call this might be their first dive into where blue light therapy or even phototherapies in general fit into the wound care portfolio. And so I'm going to give you some insight into the device that's available in Australia. Importantly, some basis of the science that underlies the therapy that we now have a much better understanding of than we certainly did 5 years ago or even 3 years ago. And I'll also summarize the more significant of the clinical evidence that's published and give you a bit of a flavour of the kind of trials that are being run around Australia. So you have an idea of where this therapy sort of sits in the continuum as it relates to Australia. First and foremost, before I dive into some contents, I need to be clear that my summary of information here is very much my own. It may not necessarily always agree with the manufacturer or the supplier. The research into blue light that I've undertaken is the best part of about almost 5 years worth now. These views are my own. And if you would like to know any more, you're obviously welcome to contact me separately. And I'll do my best to consolidate 4 or 5 years worth of learning down into a dozen slides or so for you. So first and foremost, as a bit of a content, so I'm just going to cover the actual application in science of photobiomodulation therapy. Some of you may know the term as low-level laser therapy. They are analogous. I'll also cover the mechanism of action, which I believe is all important and is often missing when it comes to phototherapies. And I'll just touch on some of the in vitro data that we started out with this particular device. I'll cover off how it works in Australia from a regulation perspective with the TGA, and also just explain to you what the device is and how you use it, appreciating that many of you probably have never used one. And like I said before, I'll cover off a bit of the clinical data. That'll be mostly graphs and mostly statistical significance. I'll leave the actual cases for Alison. So diving right in, and without going too deep down the rabbit hole, where does blue light fit into treatment and what's actually going on? Our tissue, our blood, or living systems are naturally present in a molecule called chromophores, and these chromophores are naturally intended to absorb light. They typically give a lot of things the color to make them whatever color they are as a result of the part of the wavelength spectrum that they absorb. With regards to the therapies we're talking about tonight, we're only talking about light in the visible spectrum. None of these none of this data or none of this information relates to UV light, which is sort of a separate basket altogether. There are particular chromophores that have very strong absorption in the blue part of the light spectrum. Those are wavelengths between about 400 and 445 nanometers. And specifically, we're looking at a type of molecule called a porphyrin. Now, porphyrins are essential for life. They have a huge role to play in oxygen transfer, oxygen uptake, and oxygen everything, really, with a lot of our cells. For example, these porphyrins are often in complex with hemoglobin. They have a very active role with oxygen in our biochemistry. And conveniently, they have a very strong absorption of blue light. And so by using blue light, we can activate these molecules, particularly the porphyrins. And when they're activated, they generate reactive oxygen. And the reactive oxygen is generated very locally to wherever the exposure is. And it's this generation of reactive oxygen that instigates all sorts of biological activity. So this is as simply as possible what's going on when we apply blue light to living tissue or living systems. We're activating blue sensitive molecules for the purpose of producing reactive oxygen. Before I lean towards what's actually happening or the data that we have that allows us to confirm that, I'd like to take a step back and speak to phototherapies in general. There are a lot of phototherapy devices out there, and evidence for one should very rarely be construed as evidence for another, in the way that different pharmaceutical molecules, even minor differences in molecular structure or compound structure, can have massively different effects biologically. The same is true for the various wavelengths and parameters of light. So taking one blue and another blue, or trying to compare red with orange or with green, is not really possible. The dose of treatment that's delivered is very specific to the wavelength. It's very specific to the intensity. It's also very specific to the energy density. Unless it's all of those things match, the various devices and various treatments are not really all that comparable. Most phototherapies lean on the basis that they affect the electron transport chain, or there's some part of one of the cytochrome, particularly cytochrome C and cytochrome C oxidase, and that helps with ATP production and cellular respiration and energizing the entire living system for all sorts of benefits. There is reasonably good data that is the case, but it's often spread out across dozens of different parameter groups and dozens of different devices. And so this concept is unfortunately applied quite broadly to lots of products, specifically very cheap LED face masks for anti-aging and the likes. This broad concept, unfortunately, is applied to the marketing of lots and lots of products. There are a few products that have very specific data to their very specific parameters. Therefore, there are only very few products that we can use as we would normal medical devices expecting a particular outcome. And so this concept, I don't argue with, I don't dispute. I think the hypothesis has sound basis, but we don't really know exactly how much and of what effects we think it's happening. In contrast to this broad concept, blue light has a very known quantum and a very known mechanism of action. And this mechanism of action actually comes from studies of antimicrobial activity. And so, very broadly, blue light is antimicrobial in a different way than UV light is. It has its own mechanism. Now, before I go any further, I have to say that the device that we're talking about tonight is not registered with the TGA as an antimicrobial treatment. I'm by no means saying that it should be used as one. I'm just leaning on really high quality data that was published in the Journal of Nature, the Biofilms and Microbiomes section of the journal, whereby they assess exactly how blue light is antimicrobial. And so I'm about to present 3 graphs along the bottom of the screen that just simplifications of that out of the actual study that show us exactly how we got to why we think what we think. So in the yellow bar is the control. Now the control group here is just a white lamp. The dark blue bar is the blue light treated group. On the y-axis is cell viability, and so they use Pseudomonas. And so a full bar is 100% viability, and 0% is obviously all the microbes have died. Over an hour-long treatment in antimicrobial studies, they can show that if you expose Pseudomonas to a particular parameter of blue light for an hour, you will virtually kill it. But if you expose that same Pseudomonas to white light of a different parameter, nothing will happen. So we know that blue light can be antimicrobial. How is it antimicrobial? Well, the running hypothesis is that the blue light induces oxidative stress through producing reactive oxygen, like I mentioned before. And so we can confirm that by testing the control group versus the group that gets killed versus another group that contains a reactive oxygen scavenger. So in this case, they used ascorbic acid or vitamin C, which is very effective at inhibiting reactive oxygen. It's a potent antioxidant. And so they found by including ascorbic acid in the treatment group that none of the cells died, showing that the antioxidant was an effective way to block the reactive oxygen, and thus nothing happens. So we can zero in on reactive oxygen production being a very likely mechanism in which the blue light is eliciting antimicrobial activity. We then take the third step and show if we do the treatment group and the control group, but rather than using a reactive oxygen scavenger to inhibit the activity, we actually use a mutant strain of Pseudomonas and we take the porphyrins, which we believe are the target, out of them. We show that the microbes become very merely susceptible. There's virtually no effect at all. So by using a scavenger, we can show what's happening, and by using a mutant gene, we can pretty much zero in on the target. And so we know that at the very least, porphyrins and flavins, which are very similar structures, are likely to be the target of where the blue light is absorbed, and the outcome is that they produce reactive oxygen, and at a particular threshold, that reactive oxygen becomes cytotoxic and the microbes die. So unlike a lot of other light therapies, we are very, very certain of what's going on in blue light, which helps us apply this knowledge to being a treatment, and thus we can use it more effectively. So looking specifically at what that might mean for healing and what that might mean particularly to chronic wounds, which are plagued by a perpetual state of destructive inflammation, this local increase in reactive oxygen appears to affect the inflammatory phase, as it should. In vitro studies using anesthetized rats measured neutrophil granulocytes or just inflammatory cells in general, and from that they could work backwards and work out a mast cell degranulation index. Put more simply, in a laboratory using animal models, irradiating tissue samples and comparing them with control samples showed a significant deviation or a significant change in the amount of inflammatory cells being produced. So we know that we can produce the reactive oxygen, and we know that in tissue samples that actually has an effect on the inflammatory phase, which is obviously all important if we're trying to probe the inflammatory phase of a wound. There's a graph that's not shown here, but one of the other measures they actually looked at was angiogenesis, and they could count the number of endothelial cells and could show that at a 6-hour mark there was actually a significant peak also in the number of endothelial cells, showing that we're probing in all the right places. But in vitro data should be taken cautiously. Not what works in animals always works in people. The running hypothesis really becomes that macrophages in particular are particularly sensitive to reactive oxygen concentration, and the idea that you can cause a local increase in intracellular reactive oxygen may polarize macrophage from classical to activated phenotype, thus being stuck in the inflammatory phase, moving forward to remodeling and pro-healing. Now, the summation of my research suggests that what is happening here is quite similar to what happens naturally during acute wounding. When we respond acutely to wounds, our immunological response is to recruit white blood cells, which undergo a process called an oxidative burst, which is also mediated by heme enzymes like morelloperoxidase and superoxidized dimutase. And that storm of reactive oxygen then initiates a healing cascade that follows in normal wound healing and in acute phase wound healing. And the idea is that if we are sort of artificially instigating this reactive oxygen storm locally in an existing wound, it creates an environment that is analogous to an acute wound, very temporarily. And so we're forcing the body to go through the phases of healing that it has otherwise stopped and stumbled at previously. There is a reasonable body of data that goes with this that also suggests that by pushing the body's inflammatory phase into the right direction, that we get a better organization and distribution of collagen, for example. We've looked at histological examples of treated versus untreated wounds, whereby the blue light treated wounds look more like the control, the distribution in the basal layer, for example. There's a lot of evidence to suggest that we are probing the inflammatory response and we're probing it in the right direction. I'll park that just there before we get into a little bit further into some of the evidence. But before I go any further, I think it's really important that this is what separates this device specifically and blue light therapies from the other end of the spectrum almost entirely, is that we have this very known quantum of what's happening. Granted, there is still a lot to learn about exactly what kind of dose elicits exactly what kind of response, but we have a very clear idea of what area we're playing in and what levers we're pulling to do so. In the case of non-healing wounds, particularly chronic wounds that are aggressively inflamed, it is clear that this is a tree worth barking up. Going forward, the data relates specifically to the EmoLED device, which will be the theme of Alison's cases. So best for those that are new to it, that I give you a proper introduction. So it is registered with the TGA as a phototherapy treatment as an adjuvant to the healing of acute and chronic wounds. It is a very broad brush registration. Most of the data is in chronic wounds, but there's also some pretty good basis that it could be used in acute wounds. The data just does not exist. And so at the moment, we really focus on chronic wounds. The indication is where progression and healing has stalled despite a high standard of care. And the despite a high standard of care is very important. Obviously, if you're looking at leg ulcers and you can't get them into compression, there is no point. So we still need to maintain a high standard of care, but sometimes, and still quite often, healing progression fails for any number of reasons. And so once and if that status is reached, then therapy with blue light using EmoLED can be considered, and its intention is to reactivate the healing process, but it does require a minimum of 4 consecutive applications, and that's usually over 4 consecutive weeks. The therapy is suitable for virtually everyone. However, there is contraindicated in explicit neoplastic lesions where you are clearly aware that there is cancerous lesions, or patients that have pyphoria, which is a rare but quite serious contraindication to being light sensitive to treatments. If you've never seen one, or you've never held one, this should probably give you an idea of roughly how big it is. It's about 2/3 the size of an iPad and an inch and a half thick. It weighs about 1 kilo. You would have seen in the animation at the beginning that it has a swinging optical head, and you use it like a barrel of a gun to aim at the wound. It has a distance sensor at the front, which I'll touch on in a second, and it has a touch screen, which can be used while you have gloves on. Otherwise, operationally, it is really quite simple. What's packed into it? So there's some very high power LEDs that all sort of focus into a single beam. As I mentioned before, it's not UV, which is very important. It's very well tolerated by patients. As a general rule, they feel a warm, sort of tingly sensation. Importantly, also, it's not a laser. A lot of health services have rules that govern the legalities around the use of lasers. EmoLED is not a laser, so it doesn't play in that world. It's light, it's portable, it's rechargeable. It lasts about 150 minutes on a charge and takes about half an hour to charge it back up. Treatment lasts between 60 seconds and 120 seconds per 20 square centimeter treatment area. And importantly, everything is fixed and everything is automatic. The amount of energy or the dose that's delivered during therapy is completely controlled by the device. You simply just need to stand at a fixed distance, which the device tells you on screen. Otherwise, everything else is controlled for you. With regards to what we're looking to treat, most of the data is in non-healing ulcers, predominantly venous leg ulcers, more recently diabetic foot ulcers, and I guess more recently that pressure injuries. There's sparse data in surgical dehyst wounds, for example, of the abdomen. So these are our targets. However, there are unique and growing cases in the likes of radiation-induced skin reactions, or the ulcers that result from them, which again will be the theme of some of the cases. Uncontrolled IAD, and even in burns. So there are a lot of use cases, but we're really looking at ulcers to start with. A sort of a preemptive question that we often get, what's the difference when it comes to LEDs versus lasers, and what's the difference to do with all the colors? Critically important is blue doesn't have penetrative ability. Red lasers and lights and near infrared, for example, are often used by physiotherapy because they can penetrate to the musculoskeletal region. Blue cannot. It has very poor penetration, such that often you need to debride reasonably well in order for the device to be maximally effective. It's only surface active, but we're treating wounds, which are by and large at the surface. So it plays in a very different space to the rest of the spectrum. And why lasers versus LEDs? That can be a lecture on itself, but more importantly, laser dots are very small and wounds are often very big. Using a laser to cover a wound would take a very long time, and so the use of LEDs, or the use of LEDs the way they're packed into this particular machine, kind of gives you the best of both worlds. Using it, so this is pretty much all you need to know in a nutshell. There is only one interface screen. It allows you to put a longest length by widest width, and because the device distance has to be fixed at 4 centimeters, that gives you a 20 square centimeter circle. Now, if the wound is bigger than one circle, it will tell you how many applications you need to cover the entire wound. Unlike dressing companies that would have you believe that all wounds are perfectly square or a perfect rectangle, the device appreciates the reality, and so it will automatically calculate the applications. You simply just treat one section and then move on to the next, and then move on to the next as required. A typical wound is usually only 1 or 2 applications. You move the device into distance. It'll tell you on screen when you're in range, and you simply press start. If you go too close, it'll pause until you go back, and if you go too far away, it'll pause until you go forward. Otherwise, you simply count it down, and that's it. Changing gear now into the kind of data. So before you see the first-hand cases that are presented to us, I think it's important to know where this all began and certainly where it's going. Wound products are quite hard to research in reality, because the variables that go into healing are many and complicated when you're trying to randomize patients between groups, and as such, the data is often quite poor. And so I really think it's noteworthy that the inventors of EmoLED, who are based in Italy, have gone to the trouble to establish reasonably rigorous clinical trials covering a wide range of etiologies to bring phototherapies or photomedicine out of the pseudoscience category and into the photomedicine category. As I mentioned before, the hypothesis about how many of these devices work is often broadly applied and not all that well quantified. And in order for us to treat the device or treat the therapy like a medicine, we need to know the quantum of the effects that we're having. And so for that reason, I think it's important that we sort of brush over the kind of data that exists. There are 2 major trials that have since been completed in the past couple of years. One of them I'll dive into a lot more detail on the next slide, which was the Blue Light for Ulcer Reduction study. It was simply using the device for 60 seconds once a week in addition to standard care in a range of non-healing ulcers. I'll cover this a lot more detail shortly. And then in the past few weeks, the Rise Up study has been completed, which was a multi-center randomized trial in 2nd and 3rd degree pressure ulcers. Their treatment regime was thrice weekly for 60 seconds, but only over a 4-week window as patients were inpatients. So they needed to be a bit harder and faster about trying to get an outcome. And the outcome measures were changes in the push scale, as well as wound size over the 4 weeks. I'm not actually allowed to share with you the outcomes of that right at this moment. We will be able to do that very soon when we have authority to do so. But the outcomes were really encouraging. Even over a 4-week window, there was a very high probability of those that were associated with the blue light therapy group that they had considerably better outcomes than those that didn't, in terms of both size and in terms of the push scale. Running in the background is another prospective randomized trial in neuroischemic foot lesions, which is almost complete. Diabetics get a treatment duration that's twice as long. Anecdotally, over the years, it's become clear that the average diabetic foot responds quite poorly to treatment versus the standard patient, in inverted commas. And it was decided that by the manufacturer to include a treatment option for double the duration, specifically for this treatment cohort. Again, we'll share these with you when they come out. And then the final study is a randomized trial in leg ulcers, which is looking at standard care twice a week versus using blue light therapy and standard care once a week. And the primary intention of that is to show the cost comparison or the cost saving that can be achieved by enhancing care with less visits. But as a quick summary of probably the more pivotal information, so the first of these studies to be published was the Blue Light for Ulcer Reduction study. It was a multi-center clinical trial. It enrolled 90 patients with 119 wounds. It ran for 10 weeks where patients were treated once a week plus standard care versus standard care. Now, if you are reading this and you can see that there's 90 patients and 119 wounds and how that may be split, this will be very interesting. Patients were treated in the outpatient setting, and they were recruited because, well, they were all recruited for those that gave consent, but they represented a very realistic population from the community. Patients that had failed standard care, usually multiple clinicians over the years, with an average wound duration of 5.5 years. So this is a very real subset of the problem that we're trying to manage, of which the majority, about 63%, were venous leg ulcers. As I mentioned before, clinical trials in wound care are very hard to run because it's very hard to have homogeneous groups A and group B, unless you have really large sample sizes, which gets very complicated and very expensive. EmoLED is not a dressing, nor is it a solution. So it allows you to do what they do in dermatology or what they do with wrinkle creams by comparing one side of the wound to the other. And so wounds that were bigger than 5 square centimeters were cut in half, not literally, I mean with an imaginary line, or patients needed a similar sized wound on opposing limbs. Then the whole wound was undertaken with standard care, wound hygiene, same dressing, same cleansing, and only one side was treated by covering the other side with gauze. The findings of this study reported that, particularly in the venous leg ulcer subgroup, but even in all wounds, there was a really significant difference between the treated side at 10 weeks and the control side, which is really quite remarkable that there can be such a dramatic impact. And this was the first of the studies to really lean in the direction that we're onto something in a big way. Second of that is an observational study. This is much simpler and a much smaller size. They took 60 patients that hadn't healed for almost 2 years of various chronic etiology. The trial ran in 3 4-week blocks or over 3 months. The first month just saw wound size measured against standard care. They hadn't healed for 2 years, so there was not an expectation that they would change much in the next 28 days. However, at the 28-day mark, the blue light therapy was introduced for 120 seconds once a week for 4 weeks, and the healing trajectory changed really quite dramatically. The dotted line here is the average of all the wound subtypes. And then the therapy was actually taken away at the end of the 4-week intervention, and for the final 4 weeks, they were just monitored as follow-up. And this was to evidence that even a small and aggressive intervention window can alter the trajectory of a non-healing wound, and assuming that all else is kept equal, the wound will continue to heal. And finally, landing on some local evidence, the Hunting New England region in New South Wales, which comprises sort of the greater Newcastle region out into the regional and remote areas, copied the exact same trial protocol that I just shared with you, and they reported the exact same trend, which we all found quite interesting. There was only 13 patients that made it from the start to the end. as obviously they move between health services and that they can't always be followed. And these were conducted in the community health centres. But over a 12-week window, we took 13 non-healing wounds, 6 of which completely healed, 7 of which adopted a strong healing trajectory. There was an average change of about 80%, and importantly, almost everybody's pain dropped down to 0. And then finally, for those that are coming here from a podiatry perspective or from a high-risk foot service, this is just a sample of what was run at Hornsby Hospital in northern Sydney. There was 26 non-healing wounds enrolled over a 12-week window. And they managed to reduce the weeks to heal as a trajectory by over 60%. So they have a very fancy camera that they use in their department called a silhouette, which automatically calculates wound healing trends. And so we were able to take patients at enrollment or for when they turned up at the department and then measure them over the course of the 12-week treatment regime. And assess the impact on the trajectory that they were planning to heal. And so 10 of the 26 patients actually healed in the 12 weeks, and those that were remaining had about 1/3 the healing time to go. There's an example here of one of the ulcers that was about 2 years old, despite all sorts of advanced therapies that virtually closed upon conclusion. So in summary, there is additional evidence on all sorts of areas. For those on the call that would like to look into it, there's a case series recently published from a spinal cord unit. There is another one from a burns unit. There is case series from peristomal lesions, for example. This case series is particularly interesting. It includes a couple of pyoderma cases, which they seem to think that the blue light therapy was quite critical in solving. Or the Journal of Wound Care has dozens and dozens. But that's enough graphs, that's enough numbers. I hope that gives you a brief insight into everything that brought us here today, and certainly some of the information I think that probably brought EmoLED to the fold for Alison. And so without further ado, I will hand over to our wound expert. Alison works and manages her own clinic, I think I mentioned before, on the Sunshine Coast, called Total Wound Solutions, and she sees a variety of patients. She's a visiting fellow to the School of Science, Engineering and Technology at the University of the Sunny Coast, and she's a teaching associate to the School of Clinical Sciences at Monash, which is part of the Faculty of Medicine, Nursing and Health Sciences. That is enough you've heard from me. I'll see you at question time. Otherwise, I'll hand it over to you, Alison. Thank you.
Hi everyone, I'm Alison and I've been asked to share with you my experience with the EmoLED therapy device. So I decided to use this device on a group of patients that I look after with radiation-induced ulcers. So some of these patients that have cancerous wounds, they sometimes opt to receive radiation treatment to remove these cancerous lesions instead of, say, surgical excision. And unfortunately, sometimes this radiation therapy can lead to hard to heal wounds, if not, I think, one of the most difficult wounds to try and heal. So what we see in these people post-radiation therapy when their wounds do not heal is we see this inflammation and some sort of cellular dysfunction going on from that epithelial tissue that's irradiated, causing stress to the area. We see reduced collagen production, we see fibrosis of blood vessels. This leads to hypoxia and then necrosis of deeper tissues. We see a breakdown of the skin barrier, and then of course once you get that breakdown of skin barrier, you get the presence of bioburden and biofilm, which becomes a barrier to wound healing. So sometimes these wounds, they don't present initially. They can spontaneously occur months after the radiation therapy has finished, or it can be as a result of some sort of trauma to the area where the person's dropped something or knocked their leg. Usually these are seen on the lower leg. Obviously, there's also patient-related factors that impact on the severity of the healing of these wounds, such as people with obesity, or the frequency of how often they had the radiation therapy done, the total surface area that was affected, the location, the circulation. As I said, they're usually lower legs, so that those with circulatory disorders in their lower limb, their nutrition, their nutritional status, and then the timing of the radiation therapy. In this field, I think we all understand that anybody with an ulcer, it can cause serious morbidity, pain, infection, distress to the patient, acosmesis, reduced quality of life, and mortality due to the potential systemic infection. So with this EmoLED device, it is a medical device considered adjuvant therapy for acute and chronic wounds, and should be seen as part of your wound bed preparation regimes. It has 6 LED light sources. It emits blue light at 400 to 430 nanometers. These wavelengths are said to coincide with the absorption spectrum of chromophores in the blood in the wound. What this does is activate that physiological healing process, this natural healing process, in a non-invasive way via a process called photothermolysis. So for acute wounds, its action is hemostatic, and then for chronic wounds, it is said to kickstart that normal healing cascade effect. And this is via the activation of molecules, cytochrome Cs and flavins. And these are hemoproteins that are found on the mitochondria of the cells to increase the energy in that cell. So if you remember from your science days, the mitochondria and the ATP are the energy sources of our cells. The flavins, once they are activated, stimulate the production of random oxygen signals to overcome the inflammation or the inflammatory loop that's often going on in these chronic wounds and promote angiogenesis. So we'll go straight into having a look at some of the cases that I used this on and got quite good success with. So first of all, I'll just tell you a little bit of background about the patient, and then we'll have a look at the photos. So I think, the main thing to remember here is that the EmoLED device was the only thing that was different once I started, using it on these people. So I was doing best practice for all of these patients, and nothing was really moving these ulcers along. And then I introduced the EmoLED device, which was the only new thing. And then we started to see some results. So case number 1, 91-year-old lady, quite, of advanced age, health history of atrial fibrillation, chronic venous insufficiency and hypertension. So she'd had a wound on her left shin for about 15 months after the radiation therapy to treat an SCC. She reported pain that was quite low at the time, but previous to that, she did have quite intense pain. So the wound treatment before the EmoLED was regular sharp debridement and low-frequency ultrasonic debridement. Prontosan was used to clean the wounds. Antimicrobial dressings were used of various sorts over the time. Moderate compression, which was 2 to 3 times a week. And we did this for about 10 months with minimal size reduction. So the wound was originally about 3 by 3. Then when I commenced the EmoLED, which was a 10-week trial, the wound treatment during those 10 weeks, we used an antimicrobial, your Aquacel AG Extra, a Zechavit Plus for absorption protection, and the compression was a shape support bandage, moderate compression. And we did, the wound treatment was twice a week for 3 months, and the EmoLED was once a week for 10 weeks. And the wound closed. So I'll just show you here the picture. Even though it's quite small, nevertheless, it's still, been there a long time. So we've got 1.5 by 0.6 centimetre to start with. At week 4, we're already seeing quite a significant reduction in size. At week 8, it's almost closed, and at week 12, it is closed. So this lady was very happy with that over the 3-month period. The second case was also a 91-year-old female with a medical history of heart failure and chronic venous insufficiency. Her wound was on her right medial gaiter region, and she'd had this for 2 years after radiation therapy, also for an SCC. The wound treatment was the same, regular debridement of conservative sharp wound debridement or the ultrasonic, Prontosan to cleanse and soak, Apticoat, Zechavit Plus, and moderate compression hosiery. Once we commenced the EmoLED with the The same treatment was the Aquacel AG Extra, the Zecuvit Plus moderate compression garment. So nothing much changed with the wound products that went on to the wound or the compression therapy. It's just the EmoLED that was on once a week for 10 to 12 weeks. And this is her wound here, so a bit of a larger wound compared to the last one. And again, you can see that reduction in size with the EmoLED, and the tissue, the wound tissue, is much healthier by week 12. So that was quite successful. Case number 3, also quite an elderly patient, 93-year-old male. He had a medical history of cancer, laryngectomy, chronic venous insufficiency as well, and hypertension. His wound was on his right shin, and it broke down 2 months after radiation, also for an SCC, and I saw him at that 5-month mark. The wound treatment before the EmoLED was the same, debridement, Prontosan. He had some iodine products on there, and a Zecuvit Plus, and there was no change in his wound for about 4 months. It actually started to deteriorate and increase in size in 3 months. So we commenced the EmoLED again weekly for 10 to 12 weeks, and the wound products were the same as above. We didn't change anything there. And we saw a significant size reduction of 53%, and this is his wound here. And you can see quite a nasty looking wound, as they usually are. We've gone from 3.2 by 4.2 to 3 to 4.4, a little bit wider, and then 3 by 4, and then we start to see it reduce in size, and you can see it is much healthier, the tissue type again, and this wound went on to heal. Number 4, an 82-year-old male. He had a medical history of severe chronic venous insufficiency, so very swollen lower legs, and psoriasis, so his skin wasn't in great condition anyway. He had the radiation therapy to a few SCCs on his lower legs and some skin breakdown, and he had these wounds didn't heal for about 10 months, so he's getting a little bit tired of this. We started the EmoLED weekly for 10 weeks. He was using some Kenacone and Mepilex Light for the first 1 to 4 weeks, and moderate compression stockings. And then for the next 4 weeks, it was just the Mepilex Light for protection. So again, quite a small wound. It may seem insignificant, but this really bothered this man. So at week 1, it was 1 by 0.6 and it was weeping. At week 4, it was 1 by 0.5 and still weeping. And then at week 8, it was much smaller and a dry crust. And at week 12, it was closed. So he was very happy with this as well. Number 5, so this is not a radiation-induced ulcer. This is actually a pressure injury. So I got to use the device on something completely different just to see how it worked with a different wound type. A younger female with a history of syringomyelia. So she's a paraplegic. She developed a pressure injury on her buttock and ended up with osteomyelitis in the area. Went to hospital and had it surgically opened, and then came home, and we had quite a large, still necrotic area to deal with. So the wound treatment before we commenced the EmoLED was sharp debridement, Prontosan solution and soak, the use of a HydroClean Plus dressing for autolytic debridement between dressings, or Flaminol Fort, and a Zecuvit Plus, and this was done daily. The wound treatment with the EmoLED was the same, and we did the treatment weekly. And the wound closed in 4 months. So as you can see here, it's quite a nasty wound to start with, lots of necrotic tissue there to remove. In February, I decided to start the EmoLED to try and assist with that wound healing. And already in 11 days, I think you can see there, we've got some epithelial tissue rather than granulation around the edge. In 3 weeks, we see mostly epithelial tissue. And then in 10 weeks, it's almost closed, and it is closed now. So, you know, this was a really good result. And I think, you know, it's from the device that when you introduce something when nothing else is working and nothing's moving along, and then you introduce something like this and it all starts to turn around. It's quite exciting. So thank you.
All right, thank you very much, Alison. Hello. Great overview, and some really cool cases. It's hard to capture these across the service. What you're able to share with us is really unique. So thank you. We do really appreciate it. Like we've got you here for a small bite of time, and we probably won't run it much longer than maybe 10 minutes, given the time now for all. But for those that are in the audience, we would invite you to add to the question pool. Fire away, either for myself or probably more importantly for Alison, for any questions you have using the device. This is your chance to find out whatever it is that you would like. And while some of them are coming in, I have a question for you, Alison, and I can probably add something to this as well if you'd need. But one of the questions is, do you have any issues using the device over sort of bony prominences, or have you ever used it on a scalp, or has there been hardware on show or anything like that?
No, I haven't used it over any bony prominences. No, I haven't needed to, or no.
Okay.
Can you, like, do you know that, Matt? Can you use it over
I was actually
exposed?
interested to see, to see what if you had. The short answer is it should never be an issue. The chromophores that are the target are not present in bone, nor are they present in metallic objects or anything of the light. So anything other than tissue or blood is actually not even a target, and so it will just reflect it. It won't have any effect whatsoever. If you are shining it on on something metallic, probably make sure you've got the glasses on. One here for Alison. Did the exudate levels increase initially after using the device?
Can you just say that first word again? You cut in and out for me.
Sorry. The question here is, did the exudate levels increase initially after using the device? Did you
No.
find that wounds sort of broke down before they got better, or they just...
No, they decreased. The exudate decreased, pain decreased. Yeah, they just started to get better, but it wasn't instantly. Yeah, so it was probably at that 3 to 4 week mark.
That's I hope that answers that for who've sent it in. There's one here, and for the supplier's perspective, it probably won't do them any favors. But have you found instances where the device hasn't been all that effective, or even wounds maybe that you would not use it on? And if so, why? Or unknown?
No, I haven't found it not to be effective on any wound. It has been effective on every wound I've used it on, be it for symptoms like pain or inflammation or exudate. It's been effective. I wouldn't use it on a wound if I was a bit unsure about the etiology, like if I thought it might be a cancerous wound or cancer's come back, or some sort of cancerous changes. I would find out what it was first before I used it.
Understood. A question maybe from more sort of the logistics and the multidisciplinary team approach. How do you find that the conversation goes with oncologists and patients that you have shared care of? Do you know, are they receptive to it? Do they sort of let you loose with it? How does that usually go?
Interestingly, I need to talk to some of the radiation oncologists about this device. It's one of the things that I keep saying, I must talk to them about it and let them know about it, because I think they'd find it very interesting. Because, I seem to receive quite a few of these radiation type ulcers, and they're notoriously difficult to manage. So it's good to have something up your sleeve to be able to add to the treatment. But no, I haven't actually spoken to the radiation oncologists about it, Matt. I should.
That's right. I mean, I guess I think the question, as it reads here, is: do you ever get any pushback from them, or by that point have they exited the picture?
Yeah, pretty much. It's like, here you go. Here's an ulcer for you. So yeah, I don't really. I mean, I always let them know what I'm doing, but I just need to, yeah, have that conversation with them about what it's all about.
There's one here that asks, with radiation-induced wounding, do you do any of your own investigations to ensure that there's no further cancer cells, or how does that? Yeah.
Yes, yeah, definitely. So that's when they come to me, that is one of the first questions I would always ask whoever the referrer was: has a biopsy been done to make sure that the cancer hasn't come back? Because that's always your first thought. Did you actually get it all? So yes, definitely.
Um, do you have, knowing what you know now, I'm just trying to summarize a few of the questions that have come into this box together. Knowing what you know now, what would you tell a first-time user as tips and tricks using the device?
Yeah, it's super easy. Like, it's just foolproof. And it just does everything for you, like you explained, Matt. You have to measure the wound, and then you just enter in the dimensions on the touch screen, and you pretty much just push OK, and you have to position it over the wound. And if you are too far away or too close, it just stops. So it's absolutely foolproof, and it's just 60 seconds for a 20 centimeter square wound. So it just calculates how many applications you need with the dimensions of the wound that you've put in there. So it's so easy to use, and it's easy to carry with you wherever you go. Yeah. Does that answer that question?
I'd say so.
And it only takes a minute. Yeah, it takes 1 minute. So it's not like a long process, and it doesn't hurt people. And yeah, it's just so easy.
Quite naturally leads to the next question. So there's a couple here about um, how patients interact with it. Do you find that they're hesitant? Are they on board? Does it take a bit of getting
They're
them?
excited. People are excited. I guess when patients come to me, it's because they've had a wound that hasn't healed for a long time. I don't normally see wounds that are healing well. I see very complicated, complex wounds. So by the time they get to me, they're pretty desperate to have anything that I can offer. So they're excited. And when I explain to them as best as I can, not like you, Matt, but when I can explain to them how it works and it's safe, yeah, they're always on board with it. I think the thing to know too is that it's not an instant fix. It is a once a week for at least 6 to 8 to 10 weeks. So you sort of got to get that commitment with them and say, okay, this is how this works. And usually halfway through at the halfway mark, you start to see some improvement anyway, and then they get excited and they see that it's working. And yeah, so yeah.
Good. There's for all the questions that are coming in here about diabetic feet. I don't know if that's probably not your
I haven't used it on a diabetic foot ulcer. Sorry, no.
right. For all those that are asking, it's probably prudent to mention now that there's that for those that are coming to Wounds Australia in a month's time. There's a specific session by the podiatry team at Northern Sydney that are one of the selected speaking sessions. Actually, the organisers of this may have some details in a second. But I would suggest you probably come to that, and you can hear from colleagues in podiatry. Unfortunately, I don't think that's really within your typical. Not that you have a typical remit, Alison. I imagine it's quite broad.
I should try it on them. I do see diabetic foot ulcers, and I really should start to use it on them.
Perfect. So, for those of you that are coming to Wounds Australia, like I mentioned, there's a specific presentation by the high risk foot unit from Northern Sydney at 9 o'clock on Tuesday, the 15th. Alison will also be there, sharing an e-poster with some of these cases, and I believe a heck of a lot more that cover some other etiologies. The device will also be on display for use during the pre-conference workshops, the advanced technology and the advanced debridement. The device itself is not for debridement per se, but I guess that's probably an interesting principle. Alison, do you experience the hemostatic properties of the device in practice, or are they more a laboratory discovery?
Yeah, no, I haven't used it like on an acute wound or on a bleeding where I haven't used it like that. But I believe that is how it functions in acute wounds with that hemostasis.
So it'll be on a show anyway. For those of you that are attending the conference, going to those pre-conference workshops, there'll be a device floating around. But I guess more importantly, from the supplier's perspective, ReaCare will be at booth 60. For those of you that want to come and play with the machine and feel it and see it and use it, by all means come along. I think that will probably do for tonight.